Hello all, welcome back. Today we'll be discussing mainly hepatobiliary and hernias. Hepatobiliary, this is the breakdown of the syllabus. Biliary colic, acute cholecystitis, obstructive jaundice, cholangitis, hydatid liver disease, liver abscess, acute pancreatitis, chronic pancreatitis, and pancreatic cancer. So let's get started. Okay, coming to biliary colic or cholangitis. There are certain terms in gallbladder that can get confusing. So let's break down that. So we have cholangitis, we have cholecystitis, right? We have cholelithiasis, and we have choledocholithiasis, and then there is something called choledochal cyst as well as cholangiocarcinoma. So cholangiocarcinoma, it is cancer of the gallbladder duct. So is cholangitis. It is inflammation of the gallbladder duct. So this is related to duct. Cholangitis means inflammation of gallbladder duct. What about cholecystitis? It is inflammation of the gallbladder itself. What about cholelithiasis? So litho means stone, right? Litho means stone. So cholelithiasis is um, cholelithiasis. Cholelithiasis means gallbladder stone. Gallbladder stone. What about choledocholithiasis? So doco means duct, right? So that means stone in the gallbladder duct stone. Gallbladder duct stone. Lithiasis means stone. Doco means duct. So gallbladder duct stone. So these are the four terms I want you to know. Cholangitis means inflammation of the gallbladder duct. Cholecystitis means inflammation of the gallbladder. Cholelithiasis is gallbladder stone. Choledocholithiasis is stone in the gallbladder duct. Cholangiocarcinoma is carcinoma of gallbladder duct. And choledochal cyst, doco means the duct, so it is cystic dilatation of duct. So cholangitis or ascending cholangitis is known for a classic triad, which is jaundice, right upper quadrant, pain, and chills and fever. You can remember it like 3 C's, which is color change for jaundice, colic for biliary colic or biliary pain. Colic is usually termed for the pain from a hollow viscous. But so this is actually biliary colic is actually a misnomer. It's actually a continuous pain, not like a colicky pain. So it is right upper quadrant pain and chills and fever. So that is Charcot's triad, which is classic of ascending cholangitis. So how do you treat the patient? With you can treat them with broad spectrum IV antibiotic, and if they are very sick, you can take them up for ERCP, because one of the main reason for this inflammation could be a stone. So you can identify them, or you can do a sphincterotomy or stone extraction. If this fails, then you can go for surgical exploration of the CBD. Once the infection settles, you can go for an indouble cholecystectomy. Okay, so that can be the procedures. So that is a Charcot's triad, but there is something also called a Reynolds pentad, which is Charcot's triad, that is fever, jaundice, and right upper quadrant pain, along with altered mental status and shock. So that is again obstructive ascending cholangitis, which is classically seen as a Charcot's triad, but there can be two more things: altered mental status and shock, which constitute the Reynolds pentad. Now I'll come to cholecystitis versus cholangitis. So cholangitis, we have seen it's obstruction in the common bile duct with a superimposed ascending infection. That's why ascending cholangitis. So that is Charcot's triad, right upper quadrant pain, jaundice, fever, nausea, vomiting. There can be Reynolds pentad, that is Charcot's triad plus altered mental status and shock. Diagnosis can be by evidence of systemic infection like fever, chills, rigor, leukocytosis, and raised CRP, with evidence of cholestasis. That means the left is showing clinically there is jaundice and left is showing raised liver enzymes. Then characteristic imaging findings: biliary duct dilatation, stricture, and stone. Okay, that is with cholangitis. Now, what is cholecystitis? It is obstruction of gallbladder outflow resulting in inflammation of the gallbladder itself. Okay, so again, there can be right upper quadrant pain, nausea, vomiting, and there is postprandial abdominal pain, especially with fatty meals. Okay, when there is excess secretion of bile and it cannot flow into the tract because of some outflow tract obstruction, that is when you're having inflammation of the gallbladder and you're having pain with especially after having a heavy fatty meal. And there is history of biliary colic. Diagnosis by evidence of local inflammation. So there is abdominal pain. There is localized abdominal pain and a Murphy's sign. We'll come to Murphy's sign a bit later. There is a point which leads to pain, a wincing pain. We'll see which is the Murphy's point and Murphy's sign. Then there is evidence of systemic inflammation like fever, chills, rigor, leukocytosis, and increased CRP. And imaging findings: there is wall thickening of the gallbladder, there is pericholecystitic fluid, sonographic Murphy. That means again with palpation, when you get pain, that's called Murphy. With ultrasound probe also, you can elicit that pain, that is sonographic Murphy, and there can be again gallstone. So etiology for both can be stone. Stone can be in the gallbladder duct or in the gallbladder itself. There is outflow tract obstruction of gallbladder leading to inflammation, so there is wall thickening. So sonographically you can see that the gallbladder, there is thickening, there is so much sludge inside the gallbladder, like the stone, and outside the gallbladder you can see some fluid collection, that is pericholecystic fluid. Okay. Now, the causes of obstruction are mainly gallstone, cancer, okay, or obstruction of the outflow tract, which is leading to inflammation of the gallbladder, that is cholecystitis, mainly due to gallstone, or cancer, cancer of the bile duct, or pancreatic cancer, or metastasis from any other source. External compression or iatrogenic cause, uh, like ERCP and all. Workup labs include CBC electrolytes. You can do creatinine or APTT liver enzymes to look for the liver function, uh, or any cholestasis like picture. You can do blood culture to rule out any other infections or sepsis. VBG to again look for lactate and shock, signs of shock, and lipase. Imaging: MRCP or endoscopic ultrasound, that is most sensitive but less accessible. ERCP is highly sensitive and enables the diagnosis as well as treatment, especially in case of a stone for extraction and all, you can go for ERCP. Abdominal ultrasound is the first line. Like in cholecystitis, you can see the wall thickening, sludge, and pericholecystitic fluid. CT scan also can aid in diagnosis. Management for cholecystitis as well as cholangitis. Both are inflammation, so go for antibiotics. Mm. Uh, and cholecystitis, you can go for cholecystectomy, usually like a interval cholecystectomy once the infection has settled. If not a surgical candidate, opt for cholecystostomy, tube, or endoscopic lumen-opposing metal stent. In case of cholangitis, you can relieve the obstruction by endoscopic sphincterotomy, endoscopy ultrasound drainage, percutaneous drainage. So this is what Murphy's sign is. So there is right upper quadrant tenderness exacerbated by inspiration. So how do you elicit Murphy's sign? So the patient is supine, you are trying to palpate the abdomen. Always palpate in a manner that you identify which area is tender. So you do a soft palpation. Okay. So you first also can see the temperature, if there is any localized rise in temperature. Then you, when you elicit tenderness, first always go for soft palpation to look if there is any rigidity guarding. Okay. So then you do a bit of deep palpation. So each quadrant you are palpating. So when you come to the right upper quadrant, so the patient, you are palpating with the in sync with their respiration. So when you're doing a bit of deep palpation, the right upper quadrant, just over the gallbladder, what happens is when the patient is in inspiration, they have severe wincing pains that they scream. That is Murphy's sign. So this is cholecystitis versus cholangitis. I'll quickly show the difference. So this is gallbladder. Okay, so this is gallbladder, and this is the cystic duct. Okay, cystic duct means the gallbladder duct is cystic duct, and this is right and left hepatic duct, which is coming down. Okay, they join with the cystic duct. Now, what is that called? That is called the common bile duct. So, our ascending cholangitis was inflammation of the common bile duct, and it can ascend also. The inflammation can ascend up. That is cholangitis. There you are having a Charcot striate or a Raynaud's pentad. Now, the uh, cholecystitis is when there is an outflow tract obstruction right at the cystic duct. Okay, that means things cannot go out of the gallbladder, so they accumulate here like a stone. Okay, maybe due to a stone, the cystic duct gets blocked, and there is stones inside the gallbladder also, which is the most common cause of this outflow tract obstruction. So there is inflammation inside. Okay, there is sludge, and there is also pain. Okay, that is Murphy's sign. There is two more signs here which we'll also discuss as we go along and discuss pancreatitis. I'll just say the names. One is Courvoisier sign, which means if there is a palpable gallbladder which is non-tender and obstructive jaundice, then the etiology is most likely to be malignancy until proven otherwise. It is very unlikely to be stone if it is a non-tender gallbladder with obstructive jaundice. Cholangitis, again in hemorrhagic pancreatitis or ectopic pregnancy, there is an periumbilical bruising, which is hemorrhagic pancreatitis. So we have seen cholangitis as well as cholecystitis. The treatment is antibiotics. For cholecystitis, you can do a interval cholecystectomy also. So, when you do a cholecystectomy during the surgical procedure, what you're trying to identify as an anatomical landmark is the Kellogg's triangle. So, the Kellogg's triangle, it is bounded by the cystic duct, the common hepatic duct, and the border of liver, the lower border of liver. And what is the main content here? The main content is cystic artery. So that you identify the rest of the structures, you salvage the structures, you tie them to control the bleeding and all. So to identify the structure, you identify Kellogg's triangle bounded by cystic duct, the common hepatic duct, and the border of liver. So we've seen cholecystitis and cholangitis. Now coming to pneumobilia. So what is pneumobilia and what is gallstone ileus? So gallstone ileus is actually a misnomer because ileus means a non-mechanical obstruction of the intestine. But here it is not a non-mechanical obstruction, it's a mechanical obstruction with stone. So due to stone or long-standing chronic cholecystitis or a stone or any surgical procedure, there is a uh, long-standing inflammation between the gallbladder and the intestine. And there can be fistula between the gallbladder and intestine. That can lead to presence of air within the biliary system. That is called pneumobilia. So gallstone ileus, it is characterized by pneumobilia. There is some stone and there is obstruction. So there is abnormal connection between the biliary tract and intestine. It is maybe due to biliary enteric surgical anastomosis, ERCP, incompetence of sphincter of Oddi, which is the sphincter at the ampulla of Vater, which is the second part of duodenum wherein the common bile duct opens. It's spontaneous biliary enteric fistula, maybe due to long-standing cholecystitis or chronic or recurrent cholecystitis, which leads to inflammation, adhesions between the intestine and the gallbladder, and that the adhesions and that leads to inflammation. There can be necrosis, and then leads to fistula between the gallbladder and intestine, or infections like cholangitis and emphysematous cholecystitis. That is gallstone ileus, which is characterized by uh, bowel obstruction, pneumobilia, and stone. Diagnosis by medical history, clinical findings, ultrasonography can show the uh, bilia. That is air inside the biliary tract. You can see here in the arrow marks, right? Air inside the biliary tract. Here. Supine abdominal X-ray or CT with contrast. Now coming to gallstone as such, that is cholelithiasis, gallbladder stone. How do you go about managing? So when there are symptoms of cholelithiasis, so there is pain, what do? You first go for an ultrasound. If there are stones present, you go for the other management. If there is no stone, you can consider alternate diagnosis. So when there is stones present, so there is shadow or sludge inside the gallbladder. So how do you see that? Is you see the liver, there is gallbladder, and there are so many sludge here. Okay, uh, okay, something that has settled. Sonographically, that's what you can see. You can't delineate every single stone, but you can see there is some sludge, some shadow. So that you assess the predictors of concurrent choledocholithiasis. So you see if there could be stones in the gallbladder duct as well. So what are the predictors? Strong predictors are dilated CBD more than 6 mm and bilirubin 1.6 to 4. And what are very strong predictors? With that you can visualize the CBD stone. There are clinical signs of acute cholangitis due to CBD stone, inflammation and ascending inflammation. Bilirubin more than 4. So up to 4 are strong indicators. More than 4 is a very strong indicator. Moderate abnormal LFT age more than 55 and clinical signs of gallstone pancreatitis. Okay. Now you determine the risk of choledocholithiasis. If there is low risk, you go for cholecystectomy. If there are intermediate risk, that the predictors are present but not very high risk, then you may go for a preoperative endoscopic ultrasound or MRCP to confirm whether there is a stone in CBD or no stone in CBD. Or you go for a laparoscopy with ultrasonography or cholangiography to determine whether there is stone in CBD. Okay. If also you can do a common bile duct exploration along with cholecystectomy or cholecystectomy with post-operative ERCP so that you can with ERCP you can visualize the common bile duct also. Okay, now with the endoscopic ultrasound and MRCP, if there is a stone, you do a pre-operative ERCP to take out that stone. Why you are taking out the stone? Doing so much so that you identify whether there is a stone in common bile duct or not? Because the management changes, because even if you remove the gallbladder and there is a stone in CBD, the problem is still there, because cholecystitis in the first place, or cholelithiasis, uh, was there, but there is also stone in CBD, so there is obstruction there. So there should be the extraction of stone by ERCP, and then you can do an interval elective cholecystectomy in a high risk case. Okay, otherwise go for straight cholecystectomy. This is the management. So in nutshell, you do an ultrasound, see whether there is stone in gallbladder. You look for also whether you're able to see a stone in common bile duct, or if there is bilirubin more than 4 and all, which are strong predictors of CBD stone. If it is low risk, go for cholecystectomy. If there is suspicion, there is you're not sure if they have CBD stone, you can go for a common bile duct exploration during the laparoscopic procedure, or you can go for a post-operative ERCP to extract the stone. Or if they are at high risk for CBD stone, then you can do a preoperative ERCP to extract the stone and interval elective cholecystectomy, because CBD stone can then can even cause obstructive symptom. They can still predispose to many problems. Uh, gallstone, pancreatitis, and all. So you have to extract them out. Management of symptomatic cholelithiasis consists of dietary modifications, which includes decreased fat intake. You can give spasmolytics for symptomatic management and analgesia with NSAIDs. If symptom worsen, cholecystectomy. And they are also considered safe in pregnancy. So this is about cholelithiasis in pregnancy. Beginning in the third trimester, due to increased circulating estrogen, there is increased hepatic cholesterol synthesis. This is the pathogenesis behind increase in gallstone during pregnancy, and formation of cholesterol supersaturated bile. Moreover, higher progesterone causes smooth muscle relaxation, decreased and incomplete emptying of the gallbladder. So there is decreased and incomplete emptying of the gallbladder, all due to increased first increased estrogen leading to increased cholesterol synthesis, then increased progesterone leading to smooth muscle relaxation. So there is incomplete emptying. So overall lead to increased supersaturated bile with stasis of bile. So that lead to cholesterol rich lithogenic bile, and gallbladder stasis predisposed to gallstone formation. Similarly, hormone replacement, oral contraceptive can also predispose to cholelithiasis with the same mechanism. But cholecystectomy is safe in pregnancy. So um, if you can postpone till the second trimester, well and good, you can do in the second trimester. Otherwise, first trimester also you can do a cholecystectomy. Third trimester, due to the compression, due to the enlargement of uterus, the procedure itself can become a bit technically difficult and complicated. So you may have to postpone. Otherwise, as such, the procedure is safe in pregnancy. Coming to choledochal cyst, choledocho means duct. So cyst means there is cystic dilatation of the duct of the gallbladder, and there are so many types. One means there is only extrahepatic cyst. Two means there is extrahepatic diverticulum. Okay. Type 3 means there is a choledococele. Okay. Type 4A means both extra and intrahepatic cyst. 4B means multiple extrahepatic cyst. Type 5 is multiple intrahepatic cyst, which is called Kerollis disease. So what is the importance? It increases the risk of cholangiocarcinoma, and it's more common in female. Once you identify this, if it is predisposing to a problem, you have to excise and go on with the Roux-en-Y anastomosis. You anastomose with the jejunum is cut, and it is anastomosed to the stomach also. And here is one question. We'll see the answer at the end of this uh, discussion. A patient developed pain at the tip of his shoulder after an accident. He was found to have a splenic fracture. What is this sign called? Kerr sign, Cullen sign, Brudzinski sign, Great Hernias sign. Okay, if you know the answer, you can comment or keep it in mind. We'll disclose the answer soon. Now coming to liver and liver abscesses. So there can be a pyogenic liver abscess or amoebic liver abscess. Pyogenic means bacterial, amoebic means due to uh, amoebiasis. So amoebic liver abscess is the most common extraintestinal complication of amoebiasis. Okay, most individuals they do not have concurrent signs or symptoms of colitis. Diarrhea may not be present. Okay, classical presentation are right upper quadrant pain, fever, and liver tenderness. It is usually less than 10 days. Jaundice is also uncommon. And most common laboratory findings are leukocytosis without eosinophilia, like you expect in a parasitic infection. There can be elevated alkaline phosphatase level, mild anemia, and elevated ESI. So, what do you do for an amoebic liver abscess? You can give metronidazole. So this is the difference between pyogenic liver abscess and amoebic liver abscess. Pyogenic is usually multiple, amoebic is usually single. Amoebic liver abscess is most common in the right lobe of liver. Amoebic liver abscess is more acute, and jaundice is also less common. The diagnosis is by amoebic serology. For pyogenic, you can do an USG or CT or aspiration. In CT, there is a cluster sign. For pyogenic, you can give drainage as well as antibiotics, which is usually given IV. For amoebic, you can give metronidazole, followed by a luminal amibicidal. So, luminal amibicide can be idoquinol or paromomycin. Okay. Coming to hydatid cyst, this is again a cyst inside the liver, and it is caused by Echinococcus granulosus, or it's called a dog tapeworm, and it has a characteristic cyst. It's usually a single large cyst inside the liver. It's a multi-layered, multi-laminated cyst. So there is a pericyst layer, okay, which is the outermost layer. Then there is an exocyst layer and an endocyst layer. Endocyst is the germinal layer, or which is causing more uh, daughter scoliosis and maybe leading to uh, the spread. And this fluid here is highly antigenic. So you have to make sure that whatever procedure you're doing, you're not, uh, spilling that. That is why a percutaneous drainage is contraindicated in case of a hydatid cyst. Okay, so this is a germinal layer. This is a brood capsule, which is inside. You have so many daughter scoliosis, or the whole together called a daughter cyst. And this is a hydrated fluid, which is antigenic, or there is something called hydrated sand also, that when the brood capsule or the daughter cyst rupture, it can deposit down. That is called a hydrated sand. Okay, it can be visualized in the CT also. The cyst fluid is highly antigenic, and the procedure for hydrated cyst is called PAIR: puncture, aspiration, injection, and re-aspiration. Okay, this is the procedure that we follow. You can't just go in and aspirate like you would do for any like you do ascites. What do? You just puncture and you aspirate. You can't do that for a hydrated cyst because the cyst fluid is highly antigenic. So you do PAIR. Okay, or else you can do a cyst removal surgery like thing. Okay. Or you can give albendazole, okay, along with praziquantel, and treat medically also. So in case of any liver cyst, once you do a sonography, CT or MRI, and classify them as a simple, like a thin-walled cyst, or a complex cyst, anything other than simple, the management line differs. So if it's a simple cyst, if it's asymptomatic, you can reassure the patient. If it's symptomatic with fever and jaundice, you can fenestrate. If it's a complex cyst, like infections, abscess, hydatid, or amoebic cyst, you can take culture fluid or blood. You can do the titers for the diagnosis of Echinococcus granulosis. And abscess, you can drainage with antibiotics. Amoebic, you can give anti-amoebic agents, metronidazole. Hydatid, you can do pericystectomy after treatment with albendazole. And if it's a hemorrhagic cyst, which is bleeding into the simple cyst, um, you can fenestrate if it is symptomatic. If it's a polycystic disease which is associated with the autosomal dominant polycystic kidney disease, you can do genetic screening. You can do a brain scan to look for aneurysm, because autosomal dominant polycystic kidney disease can predispose to um, polycystic diseases in the liver, and it can also predispose to aneurysm, and also it is like the cause of death in patients with ADP kidney. You can check for the kidney function to look for the renal status and resect if symptomatic. If it's neoplasm, look for the nodularity of the cyst wall, growth rate, and the tumor markers. You can do a formal resection. Okay, transplant if appropriate. So this is about cyst. You have to know for hydatid cyst, you don't do upper cutaneous drainage, you do pair, uh, that is puncture, aspiration, injection, and reaspiration. Coming to pancreatitis. So pancreatitis can be in chronic alcoholic, or can be due to other etiology as well. So in pancreatitis, what you need to mainly remember is the prognostic criteria. So there is one criteria which is called Ransen's criteria, which you do at admission, also during the initial 48 hours. So at admission, you can uh, just remember Ransen itself. Okay, A for age more than 55, and you remember like neutrophil, that is WBC. Okay, more than 16,000. S for sugar more than 11 millimole per liter. O for OT, SGOT, which is AST more than 250. Okay, you can remember OT, SGOT. And there is another N, which remember like LDH more than 350. So OT more than 250, LDH more than 350. This is the Ransen's criteria at admission. So there is 5 criteria at admission: age more than 55, WBC more than 16,000, glucose more than 11 millimole per liter, LDH AST or SGOT more than 250, LDH more than 350. Then during the initial 48 hours, at least you remember what all criteria are there, because they can ask what is the prognostic indicator among the given following. So you have to know what all is indicated, what all is included. You don't have to remember all of the values. You can remember there is hematocrit, there is so a kind of like a dehydration status. So hematocrit is dropping, and or hypovolemic status, BUN is rising. Arterial PO2 is falling, base deficit is rising. Okay, calcium is falling, there is less than 2, and fluid sequestration more than 6. Okay, so hematocrit drop, BUN rise, fluid sequestration. Arterial PO2 less, space deficit more, calcium is less. Usually in questions, calcium has been asked. What is the prognostic indicator? Among the options, they usually give calcium. So hypocalcemia is one of the prognostic indicator which indicates that there can be increased mortality. So this is predicting the mortality of the patients. So if the Ranson criteria, if it's 0 to 2, mortality rate is very low. It's 1% only. If it's 3 to 4, there is 16%. If it's 5 to 6, there is 40%. If it's 7 to 8, there is 100% mortality among the patients. So this is why Ranson's criteria is important. There is also a Glasgow criteria, uh, which again includes PO2, age, mainly like Ranson only, white blood cell, calcium, raised urea, LDH. Here there is an additional, that is albumin. Otherwise everything is normal. So if in the option, usually they ask about Ranson criteria, hypocalcemia, you have to remember, and other enzymes and hematocrit drop and BUN rise with fluid sequestration and all. If Glasgow criteria by chance is asked, also remember that there is also hypoalbuminemia. Then in acute pancreatitis, there can be guarding tenderness in epigastric area and or blue or purplish discoloration. Around the umbilicus, it's called periumbilical, it's called Cullen sign. In the flanks, it's called Craig-Horner sign. Okay, other signs can be fever, nausea, vomiting, epigastric and lower upper quadrant pain. They may have ileus and shock. Okay, there is gas, this uniform gas distribution. That is ileus. Ileus is mainly non-mechanical obstruction. Now this is Ranson criteria again. WBC more than 16,000, age more than 55, sugar more than 200 or 11 millimole per liter, OT, SGOT more than 250, LDH more than 350. Within 48 hours, it's hematocrit, BUN, calcium, arterial PO2, base deficit, and fluid sequestration. Okay. Or there is a biceps score also, BUN more than 225, impaired mental status, SIRS or severe inflammatory response syndrome, that is hypotension, there is hypoxia, and all, that is called SIRS. Age more than 60 and pleural effusion, that is biceps score. Again, predicting. Just to one on chronic pancreatitis. For chronic pancreatitis, there is a surgical procedure called Puster procedure. So what is Puster procedure? There is your pancreas. What you're doing is you're opening the main duct of the pancreas. You're cutting it open, from all through the length, and you are cutting off the jejunum like you would do in a Roux-en-Y. You're cutting off the jejunum, and you're anastomosing the jejunum with this, okay, with this pancreas. So what happens is pancreas is now directly draining into the jejunum. So it is a lateral pancreatico-jejunostomy. And the duodenal end will be cut, joined to the another distal portion of jejunum. So this is a Puster procedure done for chronic pancreatitis. Just remember the name. Coming to carcinoma of pancreas. So carcinoma of pancreas, usually at the head of pancreas, there can be cancers. There are certain named signs in carcinoma of pancreas. It's called Ingelfinger sign, Trozier sign, Courvoisier sign, and there is also Troisier sign. Troisier sign. Okay, we'll discuss that in the next slide. Troisier is another thing. Trozier is another thing. Okay, so what is Ingelfinger sign? Ingelfinger means there is a palpable mass. Okay, that sign is called Ingelfinger sign. So palpable, non-tender, distended gallbladder. So that mass, the presence of that mass is called Ingelfinger sign. Now, what is Courvoisier sign? Courvoisier sign is saying that palpable, non-tender, distended gallbladder due to CBD obstruction, is usually pancreatic carcinoma. It is unlikely to be stone. Okay, because in stone, gallbladder would actually be scarred, smaller, and not larger. There can also be pain. So a non-tender, palpable gallbladder with obstructive jaundice is usually due to pancreatic carcinoma. That is what Corbusier sign is saying. What is Troisier sign? We'll see that. So what is Troisier sign? What is Troisier sign? Troisier sign is Virchow's node or left supraclavicular lymph node. It indicates metastasis to the left supraclavicular lymph node, often from an abdominal cancer. What is Troisier sign or Troisier syndrome? It's migratory thrombophlebitis, which is recurrent clots in the veins, usually with a hypercoagulable state like in a malignancy, especially pancreatic cancer. So Troisier sign, there can be a large firm non-tender left supraclavicular lymph node, also called Virchow's node. Troisier sign, there can be painful recurrent blood clots that move or appear in different veins. That is migratory thrombophlebitis, like the name. Mechanism is by lymphatic spread from abdominal organs to left subclavian vein. Troisier sign is due to the tumors releasing procoagulant factors, which leads to thrombosis inside the vein. Troisier sign can be associated with pancreatic, gastric, colon, ovarian cancer. Troisier sign or migratory thrombophlebitis mainly with pancreatic, but also lung, gastric, ovarian cancer can also show Troisier sign. There is another Troisier sign which is carpal spasm associated with hypocalcemia or hypoparathyroidism. That is when you are inflating the cuff of BP cuff. Uh, there can be carpal spasm which you can elicit. That is with hypocalcemia. This is Troisier sign with which is Virchow's node, and Troisier syndrome, which is migratory thrombophlebitis. Then there is a Whipple procedure for pancreatic cancer, wherein you're removing the gallbladder, the bile duct, the duodenum, head of pancreas, and the tumor, and you are anastomosing. So what all you are anastomosing? You are doing a hepatico-jejunostomy. So hepatico-jejunostomy means or the bile duct is connected to the jejunum. That is called hepatico-jejunostomy. There is a pancreatico-jejunostomy and a gastrojejunostomy. Okay. So first there is infrapancreatic superior mesenteric vein is exposed, extended coca manua, and there is portal dissection. You transect the stomach or enterectomy. You transect jejunum and dissect the ligament of Treats, rotating duodenum under mesenteric vessel. You transect the pancreas and complete retroperitoneal dissection by removing the specimen from SMV and SMA. And then you also do anastomosis, hepatico-jejunostomy, pancreatico-jejunostomy, and gastrojejunostomy. Now coming to insulinoma. Insulinoma means there is increased production of insulin. It is associated with the Whipple's triad. Now we have seen Whipple's surgery. What is a Whipple's triad? Whipple's triad means it is associated with insulinoma, which means there is low plasma glucose in the presence of symptoms. When the patient is having hypoglycemic symptoms like sweating, tiredness and all, you do the blood glucose, there is low concentration. So that means you can associate the symptoms with hypoglycemia. And there is relief of symptoms after plasma glucose is raised, or you are administering dextrose and the patient suddenly gets relieved. So you can reassure that it is due to hypoglycemia. And symptoms are consistent with hypoglycemia, so it is Whipple's triad associated with insulinoma. Now another cancer is gastrinoma, usually found, it's a neuroendocrine tumor. It is usually found in the triangle of this gastrinoma triangle, which is usually the head of pancreas or this part of duodenum, the second part of duodenum. So there is raised gastrin secretion. So the gastrin has stimulatory and trophic effects on parietal cells and enterochromaffin cells. And there can be multiple refractory ulcers, usually at unusual places like in jejunum, and pancreatic or duodenal tumors. This is a triad of uh, this gastronoma. Gastronoma is a neuroendocrine tumor, and actually gastronoma means raised gastrin production. The symptom triad is actually called the Zollinger-Ellison syndrome. Zollinger-Ellison syndrome, which is diarrhea, severe peptic ulcer, that also in unusual locations, and GRD. Okay, and it is usually associated with MEN1 syndrome. Coming to pancreatic pseudocyst, it's a fluid collection contained within a well-defined capsule of fibrous or granulation tissue. Okay, it is usually after the setting of an acute or a chronic pancreatitis. So the patient has been admitted for pancreatitis, or the patient has a history of chronic pancreatitis. Now they come with some collection, or a mass like thing. So it could be pancreatic pseudocyst. It persists more than 4 weeks. It does not possess an epithelial lining. One of the treatment procedure for pancreatic pseudocyst is a cystogastrostomy. What you're doing is you are like opening that pancreatic cyst into the stomach so that it drains into the stomach. That is, in short, what is cystogastrostomy. You can do it in an endoscopic ultrasound guided manner. So our question: a patient developed pain at the tip of shoulder after accident. He was found to have splenic rupture. What is this sign called? It's called Kerr sign. Kerr sign. So what is happening? Because there is splenic rupture, there can be bleeding. So the bleeding irritates the diaphragm. Diaphragm is supplied by the phrenic nerve. So the same dermatome is also on the tip of shoulder. So that is why there is radiation of pain to the tip of shoulder. This is called Kerr sign. What is Cullen sign? It is periumbilical bruising in case of hemorrhagic pancreatitis. Grey Turner in case of on the flanks, again bruising or ecchymotic patches due to any kind of bleeding, like maybe from an ectopic pregnancy. Brudzinski sign is seen in meningitis. So this is Kerr sign. C3, C4, C5 is the root value for phrenic nerve, which is supplying the diaphragm. So that is the dermal distribution of shoulder tip also. So that is why when there is bleeding from the from the spleen, it irritates the diaphragm and it gets referred to the shoulder. Now, what are the indications of splenectomy? It can be splenic abscess or splenomegaly. Hereditary spherocytosis is one of the main indication of splenectomy. ITP, if not if refractory to other medical management, you can go for splenectomy. Rupture of spleen, but usually in traumatic splenic rupture or splenic trauma, we usually try to save the spleen as much as possible. But if it's not, it's beyond the manageable capacity, or if there is a large rupture, severe bleeding, and the patient is in shock, you may have to opt for a splenectomy. But you have to also optimize the patient for surgery. Or if you take them up before resuscitating, they may collapse. Okay. TTP also, and splenic vein thrombosis. These are the indications of splenectomy. Here there is a mnemonic given, that is short: splenic abscess, hereditary spherocytosis, ITP, rupture of spleen, TTP, and splenic vein thrombosis. Now coming to hernias, the main hernias they have given in the blueprint as inguinal hernia, incisional umbilical epigastric hernia, obstructed hernia, and rectus sheath hemorrhage. Now, hernia in short means the protrusion of abdominal content. It can be the intestine, it can be sometimes mesentery or other contents through a defect in the abdominal wall. Okay, so that means to understand inguinal hernia, which is one type of hernia. There are other types like femoral hernia, there is incisional, epigastric, and many more. So to understand inguinal hernia, you have to know the Hasselbalch's triangle. Hasselbalch's triangle is a triangular portion which is bounded by the lateral border of rectus abdominis, on the lower side by the inguinal ligament, and
laterally by the inferior epigastric vessel. So as you can see here, inferior epigastric artery, lateral border of rectus abdominis muscle, and inguinal ligament. That is your Hasselbalch's triangle. Okay. Now there is there is inguinal canal, which is having a deep inguinal ring, which is a circular opening, and a superficial inguinal ring, which is a triangular defect. Okay. Deep inguinal ring is at a bit lateral to the mid-inguinal point. Mid-inguinal point is at the anterior superior iliac spine and pubic crest. Once you draw a line, the midpoint is the mid-inguinal point. Okay. So that is about the Hasselbalch's triangle. So here again, borders of the Hasselbalch's triangle are laterally inferior epigastric artery, inferiorly inguinal ligament, laterally the lateral margin of rectus sheath. Here is a diagram which is showing the abdominal wall muscle, rectus abdominis, after the skin, subcutaneous tissue, superficial fascia and all, deep fascia. Down that you have the rectus abdominis first. It is joining in the midline by linea alba. So just underneath that you have the internal oblique. First you have the external oblique, the muscle and the aponeurosis. Inside that you have the internal oblique. Deeper to that you have the transversus abdominis. Okay. So the inguinal canal. Okay. Inguinal canal is bounded by, so the openings are, so there is an inguinal canal which is having two rings. One is a deep ring, another is a superficial ring. Now this is the inguinal canal on the right side. Okay, this is the orientation, a little bit tilted down to the midline. Okay, so it is having an oval deep ring and a superficial ring which is triangular, and these are the boundaries. The roof is bounded by two muscles, which is the internal oblique, and underneath that you have the transversus abdominis. The anterior wall by external and internal oblique. The floor by two ligaments, which is inguinal and the lacunar, and posterior wall by transversalis fascia and conjoint tendon. That is not much important. You just have to get an orientation of this. You have to know the triangle of Hasselbalch as well. So these are the contents of spermatic cord. So in male, the inguinal canal has certain structures passing through it. In female, it is basically the remnant of processus vaginalis. Sometimes they can have inguinal hernia. It's not that inguinal hernia cannot happen in female. The overall most common hernia is inguinal hernia itself, but in females, femoral hernia is more common in females. But if you ask which is most common hernia in females, it is again inguinal. Only that femoral hernia is more common in female. Okay, just wanted to add that point. So overall most common both in male and female, it is inguinal hernia. Inguinal hernia. And that is indirect inguinal hernia. So it is inguinal hernia. But femoral hernia is more common in females. Okay, femoral hernia is more common in females. So the contents of spermatic cord are three fascia, three arteries, three veins, three nerves, and three other structures. What are the fascia? External spermatic fascia, cremastric fascia, internal spermatic fascia. So these are again the continuation of fascia from the abdominal wall into and around the testis. So external spermatic, internal spermatic, and cremastric fascia. What are the arteries? Artery to vas deferens, testicular artery, and cremastric artery. What is the vein? Vein to vas deferens, testicular vein, cremastric vein, just like the artery. And lymphatics, it is draining testis, passing through inguinal canal, drain into para-aortic lymph nodes. Okay, so testicular cancer and all will drain into para-aortic lymph node. Nerves, autonomic nerves from the aortic plexus, renal and aortic plexus, and genital branch of genitofemoral nerve. It is supplying the cremastric muscle. And there is remains of processus vaginalis. Okay. Now a little bit on indirect inguinal hernia and direct inguinal hernia. So indirect inguinal hernia, we told there is an inguinal canal. Something that is passing through the canal is indirect hernia. Direct means directly from the defect on the posterior wall of inguinal canal. Okay, so that is difference. You can see it is passing through the inguinal canal, it is indirect. Passing directly from the posterior wall of inguinal canal, or in the Hasselback's triangle, it is called direct inguinal hernia. Indirect inguinal hernia can descend into scrotum. Direct cannot descend into scrotum because that it is directly from the defect on the abdominal wall. It is lateral to the inferior epigastric vessel, that is outside the Hasselback triangle. This is medial to the inferior epigastric vessel, or in the Hasselback triangle. And to reduce that hernia, reduction means you are pushing that back into the place. You have to go upward, then laterally, and then backward. For direct, you have to go upward and then straight backward. Okay. So after reduction by pressure, you can feel this thing in the deep inguinal ring. Um Again, the defect is not palpable because it is behind the muscle. Direct, you can maybe feel the defect on the abdominal wall. After reduction, the bulge appears in the middle of inguinal region and then flows medially towards before turning down to the scrotum. However, in direct, the bulge appears exactly where it was before, because this is what is the difference is this is your Hasselback's triangle. There is lateral border of rectus abdominis. There is the inferior uh, the lateral border of rectus abdominis, inferior epigastric, and the inguinal ligament. This is your Hasselback's triangle. Something bulging out from here due to the defect in here is direct inguinal hernia. Something bulging through the deep inguinal ring through the inguinal canal is the superficial inguinal, indirect inguinal hernia. So in inferior epigastric is the landmark, lateral to inferior epigastric is the indirect inguinal hernia, medial to inferior epigastric is the direct inguinal hernia. So once you reduce the indirect inguinal hernia, you can feel that in the in the middle of the inguinal region, in the inguinal ligament. But however, in direct, it is just a defect here. So even if you are reducing, you feel the defect and the bulge the same place. Okay. So it is direct is usually common in old age due to the weakness of the abdominal wall muscle. Indirect is usually common in children and young adults. Now coming to the difference between femoral and inguinal hernia. So you have these landmarks: inferior epigastric vessel, lateral to inferior epigastric. You have the deep inguinal ring through which is your indirect inguinal hernia coming. Directly from the posterior wall defect is your direct inguinal hernia coming. So here is your direct inguinal hernia, here is your indirect inguinal hernia. Okay. What is femoral hernia? So femoral hernia means you know the band structures, right? So in the femoral the femoral vein, artery, and nerve. So this is the vein, this is the artery, and this is the nerve. Okay, okay. They have different branches and all. So they run from medial to lateral in a van. You remember it like van. Femoral vein, femoral artery, and femoral nerve. Now, medial to the vein, you have a femoral canal or a space. Basically, there are some lymph nodes and all. There, you can have a defect, and the abdominal content can push through that. So, that is femoral hernia. So, you're dividing that based on the pubic tubercle. So, if you see the pubic tubercle, above and medially, you can see the inguinal hernia. Below and laterally, you can see the femoral hernia. So pubic tubercle in relation to pubic tubercle, above and medial inguinal hernia, below and lateral femoral hernia. Now you're doing a three-finger test which you're placing, on the deep ring, on the superficial ring, okay, and on the femoral hernia area. So where do you get an impulse? It is on the index or the middle finger based on whether it is direct or indirect hernia. Femoral you get on the ring finger. You just may not have to know the full details of the three finger test. Inguinal hernia is common. Actually, inguinal hernia is the most common hernia, but femoral hernia is more common in females. That's it. Okay. Strangulation is more common with femoral hernia, and inguinal hernia is 10 times more common than femoral in both females and male. Okay. Now there are certain terms which I want to highlight: incarcerated, obstructed, and strangulated hernias. What is an incarcerated hernia? So hernia which can be, hernia means it is a protrusion of the abdominal wall content through a defect, basically inguinal and femoral or epigastric or umbilical or incisional, whatever it is actually protrusion of the abdominal content. It may be a mesentery or the small intestine or whatever. It is pushing out through that defect. So usually the hernia, there is one thing called cuff impulse. When you're cuffing, you can feel that hernia out. So usually that is one classical feature of hernias. So when that hernia is coming out, you can actually push that back into that space. That is called reducibility. And while you are maybe lying down itself, it spontaneously goes back. That is called reducibility. Now, what is irreducible hernia? That hernia, that is coming out through a small defect. Through a small defect, maybe a big wall has come out. Now it cannot go back. So one irreducible hernia, where the irreducibility is due to adhesions within the sac in the absence of obstruction or strangulation, is called incarcerated hernia. Now, what is obstructed hernia? So there is in hernia there is something called sac and content, right? So sac means what is coming out, and content means usually the bowel loops, which is inside. That is called the content. Now, incarcerated hernia means there is adhesions within the sac, okay, in absence of obstruction or strangulation. So actually there is nothing, there is no obstruction in the defect or something, but it cannot go back due to the adhesions within the sac and the contents. Okay, that is what is called incarcerated. Okay, what about obstructed? Obstruction in the bowel within the hernia by 4 cardinal signs, which is pain. Okay, due to obstruction there is vomiting, and there is distension and constipation. Okay, so there is vomiting, there is constipation, there is distension and pain, because maybe the abdominal contents which has come out now cannot go back through that defect. That is obstructed hernia. Now, what is strangulated hernia? So which like an obstructed hernia which has now also compromised in their blood supply. Okay, occluded blood supply by pressure at the neck of the hernia. So this is the neck. The narrowest portion is the neck. At the neck, there is compromised blood supply, which impairs the viability of the bowel. Okay, that is what is called strangulation. Order of occlusion is veins, then arteries. First, usually the veins is occluded, then arteries, producing gangrene. Before that, you have to intervene, especially in a femoral hernia where the strangulation is high likely. You have to most likely go for surgical intervention. Now I'll talk about certain named hernias. There are terms with hernia which you have to know. Here is one question. One patient has abdominal pain, vomiting and constipation for about past 12 hours. Past surgical history of laparoscopic gastric bypass 18 months back. Chest X-ray, abdominal X-ray showing multiple air fluid levels. So there is some kind of an obstruction. Okay, there is vomiting, there is constipation, there is pain. So what was the 4 signs? There is pain. Okay, there is constipation, there is vomiting. Okay, and there is dilatation. That is why you are having multiple air fluid levels. That is the 4 features of what? Obstructed hernia. So especially in the setting of a bypass surgery, you can have internal hernias. What is internal hernia? So in a case where the patient has undergone some surgery previously, there can be some defects Okay, especially in here and all, there can be some defects. So that is called Peterson defect. Peterson defect. There are other defects also, mesocolic defect, Peterson defect, or enterostomy defect. All of this together is called internal hernia, mainly as a complication of a surgery, any abdominal surgery. Okay, just remember that there is internal hernia. One of them is Peterson hernia. So if you find, like in this question, there is one option which is saying Peterson hernia, it could be that. Okay, this is all signs of obstructed hernia: pain, vomiting, constipation, and abdominal distension. Now we'll talk about some more hernias. So for hernia, we told there is a sac and there is a content. Hmm? Usually the content is bowel loop, but it can be things other than bowel loop. Then we name them accordingly. Okay, and also based on the defect, also we name them, like incisional hernia, in the past incision, umbilical hernia through the umbilicus, or paraumbilical hernia can be there. Okay, and there can be epigastric hernia, okay, in the epigastric region, or there can be uh, diastasis of recti also, especially in post-op ladies. It's actually not a hernia-like thing. It is. I told you. I just wanted to add this. Okay, I haven't added a picture on that. I just wanted to add this. There is rectus abdominis muscle, and it is connected in the midline by linea alba. Now, in a post-op lady, maybe after cesarean section, this linea alba can give away, and there can be a defect in the midline, and some abdominal content can come out of this, especially when the lady is doing some heavy exercises in the post-op period. They can feel that there is a bulge in the center of their abdomen. There can be a diastasis recti. Now we'll see this question and some terms related to hernia. Patient presents with abdominal pain for the past 12 hours associated with vomiting and constipation. So that means it's an obstructed hernia. He has past history of laparoscopic gastric bypass 18 months ago. Chest X-ray showed multiple air fluid levels. We have seen this question, right, without the option. So if these are the options, what could be the case? Okay, it's amyant hernia, Madel's hernia, small intestinal adhesions, Richter hernia, Peterson hernia. So actually, here there is pain, there is vomiting, there is constipation, and he has undergone gastric bypass, and X-ray, abdominal X-ray showing multiple air fluid levels. So this is a case of abdominal obstruction, small bowel obstruction for sure. And one of the main causes of small bowel obstruction, if you say, based on the etiology, the commonest cause is A for adhesions. This is about small bowel obstruction. Okay, small bowel obstruction. Small bowel obstruction, A for adhesions, B for bulge, that is some kind of hernia, C for carcinoma. So if you have intestinal adhesions as an option, you have to always choose that. Otherwise, like you see here, Peterson hernia, like I told, it's an internal hernia which occur in potential space posterior to the gastrojejunectomy. Okay, so that can also be an answer, but important cause and most common cause is adhesions. Okay. Uh, Now, what is amyant hernia? Amyant hernia is a rare type of inguinal hernia in which appendix is contained within the hernial sac. So that is based on the content we are naming. If it is appendix, it's amyant hernia. What is a Madel hernia? It's a W type of hernia. That is, bowel is there are two bowel loops like in a W pattern. Okay. Why this is important? Because these all are more likely to get obstructed or strangulated. Okay. And there is Richter hernia, which means there is only the anti-mesenteric wall of the intestine protrudes, causing strangulation without obstruction. That means only, so there is a sac, and the only the part of bowel, we say that only part of bowel loop comes in, so there can be strangulation. The blood supply can get compromised, but there is no actual obstruction. Okay, we'll see each of them. Now, amyant again can be divided into type 1, 2, 3, 4. Type 1 means there is normal appendix. Type 2 means acute appendicitis with no abdominal sepsis. Type 3 means acute appendicitis with sepsis. And type 4 means acute appendicitis with abdominal concomitant pathology. Why we are categorizing? Because the management changes. In type 1, when there is normal appendix, you can go for reduction or appendectomy. And type 2, you can go for uh, appendectomy again. Type 3, maybe with sepsis, you may have to first stabilize the patient and take up for laparotomy. And type 4 also laparotomy. Okay. So that was amnion hernia. Now these are different types of hernia. Richer hernia when only part of the bowel loop is inside the sac. It can very well get strangulated without getting obstructed. Pantaloon hernia is direct plus indirect inguinal hernia. Amnion hernia is when you have the appendix. Sliding hernia when you have the colon as part of the sac. Okay, colon as part of the sac. Meckel's diverticulum, you call it litter hernia. Litter hernia. And medial hernia is when there is a W shape. M for W. Remember M for W. Amnion is appendix. A for A. Meckel is litter. Okay. So any hernia containing Meckel is called the litter hernia. Okay. Meckel diverticulum is actually abdominal outpouching of the small intestine. Middle, we have seen there is adjacent loops in a W-shaped portion, so the it can get strangulated and necrotic. This not the something that inside the sac may get strangulated. Other than that, this intervening portion that is there, which can get obstructed in the neck of the hernia and can get uh, gangrenous. Okay, that is measles. Richer is anti-mesenteric wall of the intestine. Okay, here only one part of the intestine, only one wall of the intestine. This is where the mesenteric attaches. This is the anti-mesenteric border. So only that is protruding into the sac, and that can get strangulation and necrosis in the absence of actual obstruction. It is rare but dangerous. Now these are based on the location. It is epigastric around the umbilical. There can also be paraumbilical. Any incision, there can be incisional hernia. This is inguinal hernia. This is femoral hernia. Then there is spigelian hernia. Spigelian, what is it? There is rectus abdominis muscle, as you know, and there is transversus abdominis muscle. This is called, in between that, what you have is called the spigelian fascia. Through that, if something is protruding out, it's called a spigelian hernia. So that's all. Thank you. We'll discuss the rest of surgery